Welcome everybody to the next talk in nuclear cardiology. This one is in advanced cardiac nuclear imaging. I'm Dr. Arif Sheikh from Mount Sinai Hospital in New York, and this is part of the series of cardiac nuclear medicine. The other two belonging to basic SPECT imaging and cardiac PET imaging. This will be a talk about miscellaneous topics that are important to know that are clinically being done in cardiac nuclear imaging. So we will cover some aspects of SPECT-CT technology, also myocardial viability detection, also talk about MUGA scans, first pass and shunt studies, and the latest development, which is cardiac amyloid imaging, all of which are now being used routinely as part of nuclear cardiology. So speaking about cardiac-specific cameras and SPECT-CTs, cameras have been designed to deal with cardiac-specific issues. As you can see, for example, in this specific design here, the basic concept of having two heads is similar to a general SPECT camera, except this is the heads are smaller, so there's limited field of view, but it also allows the detectors to be closer to the patient. The patient is therefore able to sit on a chair as opposed to lay on a table, so there's improved patient comfort, which results in decreased patient motion, and also improves things like cardiac diaphragmatic separation because of the positioning of the patient. So all of which go towards improving the patient experience, but also imaging of the patient and getting better scans overall. But there have been further developments of these cameras. Aside from modifications seen here, there are new collimator designs and newer detector systems, CZT systems, which we'll be getting into. One of the newer cameras that is of a newer design is the D-SPECT camera. It does use CZT technology. Instead of having two detectors that move around the patient, here we can see that the detectors, there are actually 9 solid-state detectors which are housed in the unit, and these 9 detectors kind of sweep their field of views across the patient, but specifically around the region of the heart, and independently acquire images. The result is that you get a significantly increase in sensitivity and improved resolution as a result of the technology. So for example, if you take thallium images, which is the lowest resolution of all the SPECT tracers, we can see how it looks like in conventional imaging. This is a pretty good looking scan on the conventional imaging side. But if you take the same thallium image and you image this patient in the D-SPECT version, you can see that there's an improved resolution, and these images actually looked more closer to the technetium-based tracers, if not even better than that. One of the advantages is that this is a patient who was imaged with was 560 pounds. This was done actually as a dual tracer study with a stressed thallium and with a rest sestamivi study, which ordinarily you wouldn't think is possible, but because of the CZT technology, because of all the other options that the camera offers, this could be done, and you can see that the images look very good, and especially in a 560-pound patient, these are remarkable looking images, and almost look like and actually challenge the quality of PET images. However, this is another patient which is looked at with A-SPECT or traditional Anger SPECT camera, and the same patient done with D-SPECT camera. And you can see the Anger SPECT camera, there's a very, very mild infrareceptor wall defect, hardly even noticeable, and ordinarily you might even just ignore it. But in the D-SPECT camera, that certainly shows up a lot. Now, you could argue that this is ischemia, but in this case, this was due to diaphragmatic attenuation issues, and of course, when you're reading the scans, you're never completely sure. So even though you have these cameras, some of the issues with attenuation never really go away. So, of course, we get into trying to correct attenuation, and there have been several methods in the past using rod sources and other design of SPECT cameras, trying to create an attenuation map using external sources, and then using attenuation map to correct for the images that were obtained. But now these transmission sources essentially now replaced by transmission CTs. There's still some systems out there that have some similar capabilities, but mostly attenuation correction is done by CTs in the form of SPECT CTs. So attenuation correction can be really helpful. For example, here we see a patient that has an inferior wall defect in the stress image, and it looks somewhat fixed actually on both rest and stress, and you might think this could be an infarct or it could be diaphragmatic attenuation. However, when the attenuation correction is done, you can see that the very slight defect there now looks like there's robust uptake in both the stress and rest images. So we see that the attenuation correction in this case really helped and normalize the image. Here's another case where actually you see somewhat of a another defect, inferior wall defect, and it seems to be actually even reversible, but there's a slight defect on the rest side, more so on the stress portion. But when the attenuation correction is done in this case, the rest part completely corrects, but the stress part does not. So that does indicate that in fact there is hidden ischemia underneath this diaphragmatic attenuation. So both coexist together, and ordinarily this might not have been called had it not been for the attenuation correction showing the evidence of ischemia. Other camera designs, for example, use collimators. For example, there's the IQ SPECT camera, which uses one of the regular SPECT cameras designed to take these specific collimators. So all one would have to do is slide the collimator on, and these collimators are confocal. They focus around the heart and therefore acquire images. And because the heart is always at the center of the image, you do get a better set of count rates, and overall quality of the scan should improve. So this is an example of what an IQ SPECT may do. Is, for example, this is the non-corrected images, and you can see there's kind of a defect there in the inferolateral walls on the stress and rest study, but the corrected images show that the walls correct out very nicely, and no defects are seen. However, even attenuation correction in general can have issues. This is an example which shows subdiaphragmatic activity, fairly intense, coming up very close to the wall. So if you look at the myocardium, it looks otherwise fairly normal. There's increased activity here at the infrabasal wall, which you would think is probably due to scatter. But as soon as that delayed images were done and that activity cleared, you could actually see that there's actually a defect present in that area, and that the scatter, the adjacent bowel activity had actually covered that up. So even in SPECT CT, this and or SPECT with attenuation correction, this is a problem. It is less so in PET. You can refer to the PET lecture with regards to that. But keep in mind that your basics of nuclear imaging should be good in order to get good images. This is a similar type of picture where we see that there's a large defect extending from the septal anterior into the lateral walls, and really the inferior wall seems to be the only one, but we also that's normal, but we also notice that there's subdiaphragmatic activity there. Now as soon as that subdiaphragmatic activity clears, you can see that the entire myocardium recovers, and this is all done with attenuation correction. So again, you have to take care of the basics of your cardiac nuclear imaging in order to optimize the images that you get. So as I mentioned, the CZT detectors, or cadmium zinc telluride detectors, are being used in modern cameras, and one of their great advancements is over the traditional sodium iodide detectors, or crystals rather, is because it CZT provides substantially better energy and spatial resolution than the sodium iodide detectors. And but not only that, they've got new detector designs. And in this particular camera, as we can see, this is actually a high-end N64 slice CT camera and has multiple pinhole detectors. And none of the detectors actually move. So since there are no moving parts, the resolution is quite good. And of course, the pinholes are all focused on the cardiac area, so you can get some really nice pictures between the CZT and the focal imaging. And you've also got a high-end 64 multi-detector CT. But putting the whole system together is a substantial increase in the cost of the camera compared to traditional SPECT or even SPECT CT cameras. But now that you're able to put those cameras together, we really want to think cardiac nuclear medicine is in a more advanced stage. Really, we're looking at multimodality imaging. For example, here's a patient you can see from a gated CT study where there seems to be thickening of the apical regions and ballooning over there, and we can see that there's the perfusion shows increased focal uptake in that region, mostly in the rest study, and somewhat also in the stress study. So again, relating to what we think about these diseases, we are trying to think beyond traditional ways of just looking at it with one modality. Here's an example where coronary calcifications on the CT component can be used either qualitatively, or if we've got enough good enough CT, used quantitatively in terms of calcium scoring in conjunction with the SPECT portion to improve the evaluation of patients. Now, this can be done better on PET-CT imaging, but nevertheless, SPECT-CT does offer that to some extent. Now moving on to viability imaging. So what is viability imaging? Viability imaging is post-heart infarct visualization of myocardium that is chronically ischemic under resting perfusion conditions. Why we want to detect this is because we want to help optimize medical management for these patients. These patients may be symptomatic due to heart failure, due to large areas of infarcted myocardium, but if they've got viable myocardium and that is able to be recovered with either medical management or invasive targeted intervention, it may improve quality of life and potentially prognosis in very select patients. And in some patients could actually avoid invasive procedures to improve that if we know that there is no viability in areas of myocardium. So if the question is viability, what do we want to evaluate it with? Well, you can do myocardial perfusion scanning with thallium. That's the traditional viability agent, but of course the newer agent is FDG PET. In terms of physiology, we're relying on the redistribution of thallium or the cellular metabolism of FDG to determine viability. And of course, we want to determine whether or not a patient is suitable for invasive intervention in order to improve their quality of life and potential prognosis. The agents talked about, again, thallium has a relatively long half-life. It's a SPECT agent, and FDG PET, F18, has a much shorter half-life and is on the PET side. And both can be used for viability depending on what equipment is available in the nuclear lab. And there are various different protocols. For example, myocardial perfusion scanning with thallium. You can do a stress test followed by rest studies and reinjection to get for delayed images up to 24 hours. And what you want to see is that there's ischemia, of course, in stress, which does not change with the rest, so you get a fixed defect. But on further delayed imaging following reinjection or just prolonged delay, that area, that defect you're seeing should fill in, which would suggest that there's viability. If it doesn't, it would suggest infarct. So there are various protocols you can use. You can do it without a stress. You can just do a rest and delayed rest study. You can do rest with reinjection later on. Or you could do PET with FDG, and we'll get into that shortly. So for example, here's a case where you have thallium stress at the first row, a rest in the second row, and you can see there's a fixed defect in the infrareceptal region, which on further following reinjection and delayed views up to 24 hours out, you can see that fills in very nicely, showing that there is indeed viability in that area of infarct. On the FDG side, the imaging is more complex. You do need to do a perfusion scan, which can be done with SPECT or ideally preferably with a PET agent. But in terms of for FDG, it can be acquired in a fasting state because, again, it's a metabolic agent. But it's the least accurate method if only fasting is done. So usually you want to do something like you give a trace injection after some sort of an oral glucose loading, specifically in non-diabetic patients, or they may need additional insulin injections, for example, in patients who are mildly or in pre-diabetic states. You could do it a little bit more advanced where you can actually do an insulin clamp where you run an IV insulin infusion along with a D5W line, and that's specifically more useful for diabetics, but that can be hard to do in an outpatient setting and even in a hospital setting that may have some restrictions. But the important thing in whatever method is to have insulin help drive FDG into the cardiac muscle, but not so much so that you divert FDG to skeletal muscles and away from the cardiac muscle. So here's a case where we can see a stress and rest cardiac rubidium study where you can clearly see areas of ischemia. And in fact, the only area that's really normal here in stress study is the inferior wall. The other areas, even though they have perfusion, there's a fall off of activity in those areas. But we see that there seems to be really a drop-off of counts at a somewhat fixed area here in the infralateral wall. So large areas of ischemia with some areas of infarct as well. Now comparing the rest rubidium with the FDG component of the same patient, we can see that those ischemic areas do demonstrate FDG uptake, and the most robust uptake is actually in the area of the infarcts, again suggesting that there is viability in the tissue there. This is another example of a rest perfusion study actually done with ammonia with rest FDG. There's uptake in the other areas of perfused myocardium, but the area that is not perfused also does not demonstrate FDG activity, suggesting that this is an infarct. Now you may notice that there is a difference in pattern of FDG uptake. The previous scan only seemed to show FDG uptake in the areas of ischemia and viability, but this actually shows area FDG uptake in the areas that are perfused. So there's actually a lot of variability in the FDG uptake. In order to differentiate what may be normal or abnormal uptake, there are certain things one can follow. So one has to know about what the perfusion pattern is. So really you can't look at the FDG alone. You have to know the function, you have to know the metabolic activity, and putting all that together will help you determine whether or not you'll get functional recovery. So there's a difference between normal hibernating viable myocardium or even necrotic myocardium as far as what you will see, and in between is stunned myocardium, which is an area which may have suffered an ischemic insult temporarily, and but the muscle for the most part is intact, but not fully functionally recovered. And so there is a pattern of that as well. But again, that is usually not seen these days, as patients who are chronically ischemic are really studied rather than those patients who may have had an event in the more subacute setting. There is another protocol where using technetium-based SPECT tracers, such as sestamib and even tetraphosphamine, where you can do a baseline technetium rest study, and then you give nitrate administration, and followed by a technetium trace injection, and then you image following that, and then you compare the pre and post nitrate images. And what do they do? Well, nitrates determine venodilation, preload reduction, and a decrease of ventricular volume and wall stress, and a reduction of myocardial oxygen demand. A redistribution of coronary blood flow is possible towards ischemic regions by the reduction of ventricular and diastolic pressure. And therefore, sestamib scintigraphy associated with nitrate administration has improved the diagnostic accuracy in the detection of myocardial viability. So what we're looking at is areas of viability that would demonstrate system B as a result of nitrate stimulation, which may be defects in the pre-nitrate images. And there are now newer technologies such as PET-MR. We can see that there's metabolic imaging that can be combined with the MR component. Here you can see a really thin wall suggesting an infarct, and you can see that the FDG uptake in this area is not as robust as well. That would again suggest an infarct. And another example of where cardiac sarcoid can also be studied with things like PET-MR. And there are separate lectures on cardiac PET imaging and inflammatory cardiac imaging that you can refer to with regards to those disorders. And why PET-MR may be useful in those disorders. Here's a situation where you have an MR image in the end-diastolic and systolic volume, where you see that the muscle seems to be in good shape, but it doesn't seem to be contracting properly. And when you look at the metabolic component, again, you see that the metabolism is altered in the apical region, whereas the rest of the myocardium, it seems to be fine. And again, as I mentioned earlier, looking at this in this multimodality fashion really helps us understand some of these disorders better and what may be going on both physiologically, metabolically, and perfusion-wise in these disease states. Another form of scans, the MUGA scans, also known as radionuclide ventriculograms. These are not very often used and are being used less and less, but they still remain the gold standard for accurate assessment of ventricular ejection fraction and function, specifically when compared to echocardiogram. And the reason for that is there's less inter-observer variability, there's more reproducible and repeatable than echocardiograms in general. But they are also more labor intensive, they're costly, and have ionizing energy exposure, which of course echocardiograms do not have. But other things can be done with MUGAs other than just looking at ejection fraction, for example, to assess shunts in addition to function, although again, a lot of these are rarely done now. So what are the agents that we use? Well, for MUGAs, we're using technetium RBCs to do MUGA. We can also do first-pass imaging. And notice first-pass imaging can also be done with sesame B and tetraphosphine, and we will get to those a little bit later in the talk about what first-pass imaging is, but certainly these traces can be combined with regular myocardial perfusion studies to add on first-pass with all the other information you get. But in terms of MUGA, it's the first-pass can be done along with the EF evaluation of the left ventricle. So traditionally, MUGAs are done as a planar study with best view in the LAO position, because that separates the LV out the most from other structures such as the LA and the RV, and thus gives you the best judgment of what the ejection fraction is. But additional positions are also required, such as the RAO and left lateral, which may also be helpful in assessing wall motion abnormalities. They may be used to better assess LVEF when echocardiograms results are limited, for example, but most often are used in setting to evaluate post-chemotherapy related cardiomyopathy, and in some cases also following CHF. Here is a study of a patient whose status was CABG with an ischemic cardiomyopathy, in fact, and we can see this is the RAO, LAO, and left lateral views, which we can see the end diastolic on the left side and the end systolic images in the right column. And you can see right here that the LV end diastolic looks okay, but in end systole, the LV does collapse, but a fair amount of ventricular chamber is still there, and you can see that there's still something that seems to be dysynchronous or dyskinetic with regards to the left ventricle, and this actually turns out the patient had an aneurysm that can be seen on MUGA. So again, some things can be picked out that one sometimes does not expect to find. There are various ways to actually administer RBCs. We have to label them, and there are different ways to label them. The first one is in vivo, where we want to inject pyrophosphate into the patient. The pyrophosphate attaches to the beta hemoglobin of the patient. And so what we do is we wait for the pyrophosphate to circulate and then inject the patient with protectanate, which will tag the pyrophosphate, and then you can scan the patient. An alternative way is to do it in vitro, where you withdraw a sample of blood from the patient, and then you label that sample with pyrophosphate protectanate so that you have a well-labeled sample, and you take that sample and re-inject it in the patient, and then you image. And finally, there's an in vitro method, or otherwise also known as a modified in vivo, which is a kind of a combination where you initially inject the patient with pyrophosphate, you wait, but then you withdraw blood from the patient, and you label that sample with protectanate. So again, you've got a well-labeled sample, and you re-inject the patient. Now, what's the difference between the three? Well, the in vitro delivers best labeling efficiency. It's very high, but it is also the most labor-intensive, time-consuming, and the most costly studies. In vivo, on the other hand, is the cheapest, but radiolabeling efficiency is only 85%, and that is considered optimistic by many. And radiolabeling efficiency can also drop even further. For example, if somebody's anemic, specifically if their hemoglobin is below 8 or lower. And in vitro or modified in vitro imaging is considered a compromise between the other two methods in both efficiency and labor intensive and cost of those two methods. Now, an alternative possibility is to use technetium HSA, which is human serum albumin, because that does not require any tagging to take place of the hemoglobin, and it's good for patients with anemia as opposed to in vivo imaging. But the problem is that if somebody has third spacing of fluids and therefore the tracer, for example, in CHF, that can be an issue, and you would have to image it fairly quickly so that while the HSA is still sufficiently there in the blood, otherwise you'll get a lot of background noise as the tracer starts third spacing into the soft tissue. And the other problem is HSA is not routinely available, so it may not be feasible to do. Now, MUGAs, like I mentioned earlier, is used in chemotherapy, most specifically monitoring doxorubicin therapy. This is an outline of how a patient may be monitored. I won't necessarily get into the numbers, but suffice it to say you do a baseline, and then you may do a follow-up at certain levels of chemotherapy once they're given, and once you cross a certain dosage level, if everything remains the same, you may do more close follow-up, or there's an alternative to do less monitoring in a more cost-effective fashion. But then again, you want to make sure that if you do see changes in ejection fraction, specifically if it's the baseline ejection fraction was normal or abnormal, that you do want to have some sort of a reliable method to monitor that, and echoes may not always provide the most reliable methods. Or if echoes are being used to follow and there are changes that need to be verified, then MUGA can be used to do so. But MUGAs are not only used for monitoring chemotherapy. Other chemotherapies, such as in this case Herceptin, have also showed similar algorithms to be able to use MUGAs or some sort of EF monitoring in order to deliver these therapies. So, and there are a slew of other therapies that have a similar type of algorithms that can be used, and MUGAs can certainly provide that in a very accurate fashion if it is used. But as I mentioned, also MUGA can be used for monitoring CHF and valvular disease. It is frequently used for follow-up of CHF. And again, if echo results are equivocal, or if there's aortic valve regurgitation, MUGA could be helpful. In other disease entities such as chronic mitral regurgitation, there is some literature suggests that a stress MUGA, a rest and stress MUGA, so a MUGA obtained at rest and then at the time of stress, it could be a sensitive indication of overall prognosis, because you could get LVEF. You might also be able to get RVEF using a first pass study. So there is indications of being able to do surgery given certain LVEF and RVEF. Knowing accurate values could be quite important in terms of appropriately managing the patient. But one of the newer developments that has taken place is the use of biventricular pacing. And because in some situations the myocardium is contracting in a dysynchronous pattern, and by setting pacer leads in the correct position, the myocardium can be made to beat again in a more synchronous fashion, and therefore not only improving the patient's quality of life, but also overall prognosis. And certainly MUGAs can be used to analyze the beating patterns and direct physicians and cardiologists to be able to place the pacemaker leads correctly so as to improve any dysynchronous contraction that may be taking place. Another aspect, an older aspect of being able to do cardiac nuclear imaging is shunt and first pass studies. And again, most of these are almost completely replaced by echo. There are various depending on what you want to look at, right to left shunt, to left to right shunt, they have very different approaches on how these are done. Right to left shunt, you want to look at extra lung activity, whereas in left to right shunt, you do an RBC scan, you can evaluate the RV function, you look at graphs examining recirculation times, and the assessment is made by looking at time activity curves, and then by looking at these curves, abnormally short times indicate that the shunt is present. And if you were to just look at all these images visually, it would be extremely difficult to analyze them. So, for example, in a first pass study, the study is done as a flow protocol where you inject and then you do dynamic imaging, but with EKG gating. And this is done to assess RV function because as the bolus passes through the RV, the LV and other structures around it do not have activity, so you can isolate the RV for a very short but specific time period. But you do still have to account for a little bit of overlapping RA as a result. But and the fact that you have to have a very good bolus for accurate assessment, because if you have a distal bolus or something that's moving very slowly that diffuses out, it will be a poor study. And if you have arrhythmias, for example, that can invalidate first pass studies as well. And as I mentioned earlier, these first pass studies can be done in conjunction with MPI, myocardial perfusion imaging. And in fact, SPECT-MUGA can alternatively look at RV function in lieu of first pass studies. So the agents used in the various studies as mentioned are technetium MAA, which is used for looking at right to left shunts, and RBC is looking for left to right shunts. And why that's important is because MAA is used to look at for lung perfusion imaging, but if you've got a right to left shunt, then you will have tracer that will go through, whether it's through AV nicking or some other shunt that may be present, bypassing the lungs and going into other capillary beds such as the brain and kidneys. So when you do see this, you know you've got a right to left shunt present, and you can actually quantify the amount of radioactivity that's outside the lungs and see what the percentage shunt is. So it's a fairly easy study to do. The left to right shunt, on the other hand, is where it's problematic because this is where you have to do a first pass and you watch the bolus that goes through the RV and into the lungs and eventually into the left side of circulation, and you create a time activity curve. And going back to your basic physiology medical school lectures, looking at QPQS and the ratio of the pulmonary to systemic flow will give you the shunt ratio. So again, various shunts can be evaluated based on knowing what the time activity curve should look like for those shunts. But as mentioned at the beginning of the talk, the newest arrival in the clinical realm that is being used routinely is for looking at cardiac amyloidosis with pyrophosphate imaging. Again, it's increasingly being recognized as a frequent cause of non-ischemic cardiomyopathy. There are treatments now available for subtypes of amyloid cardiomyopathies, and it is FDA and CMS approved. It's relatively cheap and easy to do. It avoids myocardial biopsy, which is the gold standard, but the problem is that it has a high false negative rate and has significant morbidity associated with it. So having an imaging study that can do that in lieu of the biopsy is extremely useful. So it's not that the pyrophosphate can find any amyloidosis, but we're targeting specific types of amyloidosis. So in a patient who has known amyloidosis or highly suspicious for amyloidosis, and one wants to determine what kind of amyloidosis that they may have, that is where pyrophosphate imaging is used. So for example, here's a patient with amyloidosis with no uptake of the myocardium, but another patient that does have uptake of the myocardium. What's the difference? Well, this patient has light chain amyloidosis, which generally does not have uptake, but transthyretin amyloidosis does have uptake because there's a lot of times this calcium deposition that is taking place. On the right side, this is an incidental bone scan that was done, not pyrophosphate, it's just a regular bone scan that shows incidental myocardial uptake, and this can be seen on bone scans, which suggest calcium deposition. It could be due to exactly that or related to amyloidosis, but when you do see it, it does need further workup. This is a study that showed that why pyrophosphate imaging was so useful, that it was able to separate out. If you took the ratio of uptake of the myocardium on the planar images and looked at it in the contralateral chest wall and looked at that ratio of uptake, you could nicely separate out light chain amyloid from transthyretin type amyloid. Now, transthyretin itself has two different types, the wild type and the mutant type. So certainly you could separate the wild type out, and you could separate most of the mutant type out. In some cases, there may be some mutant that overlap with the light chain variety, but certainly the wild type you could separate out, which could be important in terms of treating a lot of these patients. So what do? We do planar view of the chest up to 1 hour, and you can probably do it up to 3 to 6 hours post-injection. You want to calculate the heart to contralateral chest ratio. You do a visual analysis and assessment of what you see. And if you do have capability of SPECT CT, it may be helpful in looking at myocardial uptake, because sometimes it may be difficult to differentiate between myocardial uptake versus just blood pool activity that's still sitting in the heart, because of course many of these patients are in heart failure. This is the study that showed that looking at looking at not only visual score but heart to contralateral chest ratio, and showing that actually the overall performance was similar in whether it's 1 hour incubation or 3 hour incubation. In terms of the sensitivity specificity, and so overall, there you could probably get away with 1 hour. But again, as I mentioned, if there's significant blood pool activity, you may be better off in some cases doing a 3 hour image, because the specificity in those cases may be better. So the heart to contralateral chest uptake is important, because as we can see, the ratio, just looking at the ratio portends what kind of prognosis the patient has. A low ratio would suggest a patient does much better overall than patients with a higher ratio, which of course shows that a patient with amyloidosis is going to do worse. But as I mentioned earlier, you could run into this reading very different parts of nuclear imaging. For example, this is a patient with prostate cancer who had PARP therapy, and after the therapy, we can see this myocardial uptake. And again, you need to be thinking whether some sort of pathologic problem is going on. So you can find these examples come up. This may be not amyloid deposition, or it could be just microcalcifications taking place as a result of necrosis, but certainly may warrant further workup, especially if the patient is having symptoms that are not being picked up. Here's a case where another patient who had a bone scan and had uptake in the myocardium, which was proved to be amyloidosis, but the same patient went on to have a sodium fluoride PET scan. And although we generally feel that sodium fluoride is better than SPECT bone scans in most cases, but not in this case. The myocardium, although it's abnormal, does not demonstrate sodium fluoride uptake. So sodium fluoride uptake is not an equivalent tracer when it comes to evaluating amyloidosis, and SPECT agents here are clearly better. So in conclusion, there is an expanding role of cardiac nuclear imaging. There's the development of new perfusion tracers. There's advancement of molecular imaging. There's the growth of hybrid imaging and neurotechnologies. And limiting radiation exposure will be key to the growth of the field. And multimodality imaging appears to be the future as well. And with that, I thank you for listening into this lecture.